Hi, everyone. Thank you for joining this month's PFCC Partners Workshop. We're very excited to have all of you and have our presenters with us today as well. I'm Lindsay Galley. I'm the Director of Education at PFCC Partners, and I'm very excited to have you all with us today. Thank you for taking time out of your, I'm sure, very busy Fridays to join us. Today, we are very excited to welcome Linda Essex and Yvonne Chan from Sutter Health Mills Peninsula Health Services. They're going to talk about incorporating person-centered care across the care continuum. Before I pass it over and introduce Linda and Yvonne, I would just like to take a minute to remind everyone that we are on Zoom, our meeting platform. If you do have some background noises or any echoing, we really appreciate you managing your mute button. If you are using your computer audio, you just need to hover over your screen, which you should see the presentation shared on, and click the mute button. Also, throughout today's presentation, if you have any questions or comments for the presenters, you can use the chat box, and you can find that by hovering over your screen and clicking the chat button. I already put a chat in there, so hopefully some of you have been able to navigate to it. And I also want to remind you that a lot of the time Zoom will turn on your cameras, and so if you would like to show your camera, you can, totally fine, but if not, you can also hover over your screen and click the stop video button. Just be aware of that. We don't want to go into the bathroom with you if you're taking us around your home or office. So thank you. And if you have any questions or issues using Zoom, please just put it in the chat and I will work with you to resolve any issues. So with that, I would like to introduce Linda Essex and Yvonne Chan. Linda Essex is a nurse and occupational therapist. She has a background in mental health, which includes chemical dependency. She has worked, sorry, I'm gonna manage some mutes here. Linda has worked closely with adolescents up to older adults, and for the last 7 years, she's focused on older adults, preventing readmissions to the hospital, which is what they'll share with us today. Linda enjoys working with all populations and helping patients and families take charge in managing their own medical care. And Yvonne Chan, she has a diverse clinical background in inpatient, outpatient, and community operations. Her passion to work with older adults, with that passion, she's obtained her Master's of Nursing in Geriatric Clinical Nurse Specialist and Nursing Education. Yvonne's prior work involved oversight and quality improvements for transitions of care programs, skilled nursing facility partnerships, and population health for high utilizer groups. Some of her past roles range from charge nurse, hospice case manager, advanced practice nurse, and adjunct nursing professor. So with that, I will welcome Yvonne and Linda.
Well, thank you. Glad to be here. And thank you, everyone, for joining. Lindsay, go ahead and advance the slide. So our title for today is, this is Yvonne. Our title today is How to Incorporate True Person-Centered Care Across the Care Continuum. I think a lot of times it's really easy to say that we're person-centered, but how do we truly be person-centered in setting achievable goals, in things that are meaningful for patients? And the care continuum here, it really means across different settings, care across different settings, whether that be hospital to home, whether that be skilled nursing facility, whether that be emergency department, shelter, or with different providers. So how do we carry a person's identity and their goals and preferences across different settings, and to really looking at the overall well-being. So that would be kind of the kind of hence how the title came about. The objectives for today. Next slide, please. The objectives, so to really understand the person-centered design, and these are a lot of the learnings from a transition of care program that we're over part of, and really a lot of the learnings in working with patients in the last 7 years. And then looking at the importance of person-centered care in transitions of care, and how do we use that to improve patient outcomes as our next objective. The next one is how to incorporate their goals into improving their own health management. And we'll give lots of examples, and Linda will be really going into details on that. And the last is to learn about engagement strategy. So if you are working with patients, or if you are, you have family members or friends, how do you engage them in healthcare, in particular for those who keep coming in, who have frequent admissions to the hospital or to the emergency department. So we'll talk a little bit about that as well.
Next slide. This is Linda. There we go. So what is the most important thing to patients when they go home? This came out of many home visits that I did. I kept hearing the same thing over and over again. And so I thought I'd put it out to the general audience and see what people thought was the most important thing to patients when they're coming out of the hospital. So we'll give you a few seconds to answer that.
Yeah, Linda, this is Lindsay. We have a lot of responses coming in, so I think I'll leave it open for just another 30 seconds, and then we'll share the results.
Okay, sure, that's fine.
I have difficulty choosing the most important.
Okay, this is Lindsay. I'm going to end polling, and here are the results.
Okay, so everybody, well, there's two. I can't read this. So number one is the red, right? Having help at home.
Yeah, that was the most chosen response.
And then medications was second.
Mm-hmm.
And third was returning to the hospital.
Yeah,
very little.
One person.
And then nobody put doctor's visits.
Exactly, yeah.
So the answer is returning to the hospital. Believe it or not, out of everything that's going on, they don't want to go back. And it doesn't matter whether they had a good experience, bad experience, okay experience. I heard over and over again, I don't want to have to go back to the hospital. And that's really nice for me when I'm working with patients, because that's a great goal, and that's our goal too. So, how can I leverage this not wanting to return to the hospital with the interactions that I have with patients in their homes? So good job.
Thank you, everyone. So just a highlight of our program. So we have a program called Peninsula Circle of Care, and it is a program that's part of Sutter Health, which is a large healthcare system in Northern California. And this was a program that we had at a community-based hospital in San Mateo of California. Again, 20 minutes from San Francisco. It's a 241-bed hospital. And since our inception 7 years ago, we've touched 2,500 patients. And you can see here a large proportion of the patients that have enrolled are either at high or very high risk. For readmission, we have a tool that we use to determine risk. And we use a combination of interdisciplinary team, which comprised of nurses, social workers, wellness coach, which is a community healthcare worker or a non-licensed staff, as well as volunteers to provide support to help patients and navigate the healthcare system, connecting them to resources that are healthcare related or non-healthcare related. And when we first started this work, a lot of what we did is really getting the input from the community. So we had a community task force. We had a lot of patient representatives to really tell us what is meaningful and what gaps are we trying to meet in the community. So our high-level outcomes through this program, our readmission rate is very low. It's 5.4, and national average for 30-day readmission, essentially returning back to the hospital, the rate is at 25%. So we're really good at lowering our readmission rate. A third of our patients are connected to 2 or more resources in the community. Getting help at home is oftentimes one of the biggest needs, caregivers, and then also having access to food. And then also, all of the patients that have enrolled are very satisfied by the service that they have received. And we do a qualitative review, and also we ask questions at the end to really look at things that we can improve and what are some of the changes that they have made. We have a graph here that shows you kind of our readmission rate in comparison. So the blue line here is our hospital readmission rate. Year over year, as you can see, we have a really good consistent decline, and then the readmission rates for patients that are enrolled in particular in our program. So we definitely contributed a lot to improving the overall readmission rate of the hospital. So when we work with patients, we're going to go from a very high level, system level, down to a patient level. What are things to consider as you're working with clients in transitions of care, as they're going between settings? And this is taken from Atul Gawande's book. If you haven't read it, highly recommend it. He has a book called Being Mortal. And Gawande is a surgeon that's done a lot of work around interviewing patients, interviewing providers, and finding out what matters to patients as they age. And so one of the questions that came out of the book is around asking patients, what are your biggest fears and concerns? Many times we know patients don't want to be in the hospital in the first place, thus, really being unprepared. Many times they might be shocked of, being sick or losing control of, what happens to their body. Many times they might be fearful of, not knowing whether this will happen again or how soon this will happen again, and really not knowing what to expect next. Some of the most common concerns we also hear is, I want to go home because, I don't want, I need someone to take care of my cat who's now at home alone. The pet that I have at home is really important to me. Or I really don't want to bother other people. I don't want to be a burden to my family member. Or it could be, I'm afraid that I would fall again, not having control over their body. So those are some of the common fears and concerns that we hear. The other thing that consideration to consider is educating and empowering patients to know what to do when. And that's our next point here, is really empowering them to know when to contact the doctor, what are options they have aside from going into the emergency department. A lot of the patients, I think, when we first started this program, by default, they thought, going to the emergency room is, whenever something happens, that would be my very first response. That's where I should go. And through this program, we've really educated a lot of patients and providers to know, besides using hospital emergency departments, you have other options. So, for example, you can utilize urgent care, walk-in clinics that are available. Have you considered contacting your doctor to let them know some of the concerns and seeing whether they can see you on the same day, or utilizing some other resources? So really do our due diligence to really empower patients to speak up and pick up some of the symptoms early on. The next slide, we're going to talk about high utilizers. So this is really about patients who keep coming in and out of the hospital. And a lot of times, for those of you that are working in the healthcare system, these might be names that, as soon as you hear about it, about that patient. Or these are patients that you're like, oh, that patient is back again. So it's about how do we engage patients who keep coming in and out. So at a system level, what we've learned is it's really important to form partnerships. So really looking at who should be involved as you brainstorm on engagement strategies. So some examples that we have listed here is definitely within a hospital setting, a lot of times you want to loop in your case managers. You might want to loop in your social workers, people who know this patient the best. Staff from the emergency department, this might be the medical director from the ED department. It could be the director or it could be the front line. As soon, who do they see first? Who is the first people that they would meet as soon as they come into the emergency department? Health plans, really looking at learning about your population. Are there other staff? Are there departments within the health plan, for example, department, case management departments that would be following up with patients post-discharge. Home health definitely involved the providers from home health services, if there are any. And the most important one I would really highly suggest is really getting the input from the primary care providers and the specialists. Many times they know patients the best, but sometimes they may not know a patient keeps coming into the hospital. Sometimes they may not know that they've been in 30 times in the last 6 months. So really getting their input and getting their suggestions. And then other providers that you can think of. And so as we form this partnership, what's the goal? I think the goal is to really think about sharing information across providers, across settings. Sometimes we might be working in silos. A lot of times you'll find that high utilizers, there are already many programs that are already touching the patient. And so each program talking to each other, do they know that, for example, we're working with the patient from the hospital side, do we know who from home health is responsible for patient care? Do we know if anyone from the health plan is following up on the exact same patient? And are we all doing the same thing? How do we tag team? How do we not duplicate services? And so as you form case conferences, you bring the partners together, is really to define what's an achievable goal. Next one is really clarifying roles. Who's doing what? How do we not duplicate? Let's make sure we know who are all the players that are involved in this particular patient. And then really determining kind of who's doing the next follow-up, who's going to be the touch point. We learned that more is not better. A lot of times, especially if they have multiple services that are engaged with the patient, it might be one that's most effective. It might be one that patient most prefer to work with. And so we certainly don't want 10 different services to be touching patients at the same time, which in our experience has caused a lot of confusion. Well, didn't I just talk to someone from home health, and why are you calling me and asking me the same question? So we hear that a lot. So really keeping in mind not to cause further confusion to patients. And then also looking at preferences for notification. So if someone were to come back to the hospital, how would each provider prefer to be notified? Would it be through the electronic health system? Would it be through emails? What are their specific preferences? And then the next one is really looking at consistent messaging. Sometimes patients, especially those that into the system quite a number of times, sometimes they're pretty savvy and they really know how to navigate the system. And so if they're not getting their needs met, they may be going to other providers asking the same thing. And so part of this partnership is how do we say the same thing to the patient no matter where they go? How do we provide that consistent messaging? And what resource are we trying to divert this particular patient to? And then lastly here is timely notification. So how do we set up a system so that your partners know exactly when the patient hits the door of a hospital? So sometimes, again, we might have many providers that are involved, but sometimes they don't know all the changes that are happening. They don't know that they just went to the emergency yesterday and had left and it's now home. And so it's really setting up the system to do that. Next slide is a potential solution. This is one that we are using at Sutter Health. That's the next slide. Sorry. So next one is really diving into engagement strategies at a patient level. So we talked a lot about system structure. What does it mean from a patient perspective? So from a patient perspective, it's really important to have consistent staff. Again, sometimes for high utilizers, an organization might want to switch up providers because they feel like, well, it didn't work for that last provider. Let's try someone new to see if they can work their magic, to see if they can make any changes. And sometimes, again, that might cause further confusion. So as much as possible, have consistent staff. So no matter each time that they leave the hospital and each time that they're home, it should be the same provider who is reaching out, and it provides continuity for the patients too. And as a group, really, asking patients, how often would you prefer for me to reach out to you? What works for you? Again, we don't want to impose our agenda on patients, and it's really important to hear from them how often they want us to follow up. We might want to get updates from them on a weekly basis, but that might not work for them.
So this is Linda. Next, great, perfect. So what's the unmet need, right? What is behind somebody coming to the hospital? And this could be any number of things. Their ability to care for themselves at home when they show up, needing help. Do they have access to the correct doctors? Do they know how to call a doctor and get an appointment in a timely manner? Where do they go? And then do they feel like they can do it? Self-efficacy is a big part of what we utilized in our program. Next, you put above. Okay, transparency. So I see that your case manager is Lisa at Health Plan. When was the last time you talked to her? What do you talk about? What is she doing with you? So you kind of have an idea that, okay, and if I need to call, do you mind if I call Lisa on your behalf? And, this transparency to patients that we're working together on their side. And then obviously we touched on this previously, but feeling in control. And especially I find with new diagnoses, right? I'm the same way. If I have the new diagnoses or something, I feel out of control. There's that moment of, oh no, now what, and along with everything is identifying barriers. And when I talk about barriers, I'm talking about going up to what's the unmet need. There could be behavioral barriers. There could be social barriers. There could be family dynamics. There could be an underlying mental health condition. I had a patient that had at least $200,000 in his bank, and he spent that all down on having a caregiver. And until he came into the hospital and went home, and I did a joint visit with the social worker, and we found out he doesn't have Medi-Cal. He could have been having IHSS, in-home support service through the county, which are caregivers that come out to the home. And so what we did, actually both of us, actually was managing the medical portion of his care, okay, but getting the paperwork together for applying for Medi-Cal. And, we had to look through records and look through his drawers with him because he had trouble seeing. He was in a wheelchair. There was just sort of like, what can we physically do for him in the home to help him get the help he needs? And he was out of money, so that was one of the big issues. So as you can see, there's a lot of strategies we use. I'll give you examples throughout when I start talking about the patient-to-patient visits.
Thank you, Linda. I think the takeaway point here is not to assume. I think a lot of times, in our experience for high utilizers, I think a lot of times we assume they are coming in because they want a certain thing, but I think it's really going behind, what's behind the chest pain? What is behind the shortness of breath that you are experiencing? And maybe just throwing out a very short example, we had a patient that was coming in for chest pain. And we wanted to find out what's behind the chest pain. So as we inquire more, as we hear more from the patient, we learned that this particular patient's sister had passed away the week before, hence leading up to the chest pain. So that opened up a new door for us to really understand the patient a lot better in thinking about how do we partner with them. So I just wanted to point that out.
Yeah.
So one of the solutions that we use here at Sutter Health, and many of the systems in other states are also using, is called pre-manage, and that's in the next slide. And
sorry, Yvonne.
Pre-manage is
sorry. Can
yes.
I just stop you there while we're still on this topic? We have a couple of questions. Is that okay?
Sure.
Okay. The first is from Joe Connell, and he's just asking if there were any patient or family members, whether just patient or family members or patient family advisors, involved in any way of the design of the program, and if they were there was ongoing involvement through evaluation of the program as well. We saw some of your stats that patients and families were getting a lot out of the program. So curious how or if patients and families were involved in the design in any way.
Yeah, great question. So we've had at Mills Peninsula Medical Center, we've had a patient family advisory council for many years now, and it even started before the inception of this program. And so when we started this program, I think I spoke at the beginning, is we have two patient partners that worked with us from the inception to design this program in a way that incorporates the patient and family perspective. Mm-hmm. We also had a community task force. So we had a lot of nonprofit organizations in the community that are also involved in identifying what gaps we are meeting as part of this program. Once we've had the program up and going, we oftentimes go back to the Patient Family Advisory Council for feedback, whether it's something like a personal health record that we would use to get their feedback. Would this work from a patient's perspective? I update around, to our program. So yes, they are a very important part of our program as we evolve.
They're interwoven in that we did at different times. So yeah.
Great. That's very exciting to hear. Thank you for sharing. And then one more question before we go on. Stella asks, what HIE system do you utilize?
Do you mean the electronic health record?
Maybe
Epic?
That's EHR? Mm-hmm.
Yeah, EHR.
Epic.
Is Epic.
Okay.
As well as Stanford and a couple of other hospitals in the area. So it's really nice because now the notes from other hospitals pop up in the notes section, so we don't have to go to outside care everywhere. There's a button. So yeah, it's nice. It is really nice.
Great. Wonderful. Thank you for sharing.
Yeah, thank you. And actually a great segue into this next slide in a healthcare solution that we are using. And so this is pre-manage ED, also known as EDI. And this is a platform that allows different healthcare systems to talk to one another, to communicate, to see when patients are going into their system, when are going into their hospital. And so this was started by a case manager that worked in the emergency department. And she was just really frustrated by patients who keeps coming in. And she didn't know about the history, or she would have to ask the patient each time, and she wouldn't have any visibility into where the patients had been. And so she shared the ideas with her two sons, who are engineers, and hence they started the concept evolved into the creation of this organization. And so pre-managed ED is used in many states. It's used in the entire state of Oregon and Washington. And they're now rapidly expanding in California as well as Texas. We've had really good outcomes in working with pre-managed. As I said, it's a share. Basically, medical records are being shared in this platform that is HIPAA or that complies with patient confidentiality. What you can see in here is how often the frequency and location of visits. It provides the provider's contact information, making sure that it's up to date. Who is the one provider that is really touching the patient? And you can edit, you can change the information here so it's up to date. Who's the primary contact? If it's not the patient themselves, who is the son? Who is the friend that we should definitely reach out to? Who is the one case manager that knows this patient best, that we should pick up the phone as soon as they come into the emergency room and provide an update? This is where we can also communicate updates and recommendations. And the beauty of this is it's really nice because you can see how often they are utilizing different hospitals, and you can create trends and see that over time too. So if you have an intervention, you can actually see over time, are we actually seeing a difference in utilization of emergency departments? So one thing that we do put into pre-manage are care plans. And care plans, what we have in here, these are the kind of our bullet points to guide our care plan. Is what are we recommending is in terms of treatment recommendations. So a lot of times this is really directed to the ED providers that are there. And then what are some specific care coordination recommendations? When patients come in, we need to offer this behavioral health service that we've been trying to connect patients to in the last 2 years, but they've continued to decline. So that might be an example of a recommendation. But to be very specific, if there's, whenever they are in, please contact Casey, who is at this particular health plan, who's been following up with the patient. This is Casey's contact information. Next is really a brief summary of the underlying issues. What are the things that this patient keeps coming in with, and then what has been effective? Sometimes there might be different things that have been tried. So it's really capturing what works for this particular patient. And the 90 that's in this screen is really to be able to put in a care plan and be able for someone to read it and understand it in 90 seconds. So the point of this is how do we keep it brief and succinct in that we're not putting too much information in a care plan, but something that's actionable.
Great. And Yvonne, can you really quickly, we had a question, how does Eddie differ from Epic?
Sure. So Eddie is not it's not necessarily an electronic healthcare record system, but it's basically a software that pulls different healthcare system, EHRs, into one portal. So it aggregates different electronic health systems. So for example, if Dignity Health or Kaiser is using a different system, it pulls some of the medical records information into this one portal called pre-manage.
Great. That seems very helpful.
This is Linda. Just to add on to that, we have a patient that has been coming to our ED every 3 days or so. She had 79 visits last year. She goes to Kaiser, Stanford, our hospital, and I think one other hospital, and maybe the county. So you can imagine how difficult it is to try to manage this. Now she has an underlying mental health problem that is complicating the whole thing, and her brother doesn't want to be that involved. So we got together recently for a conference call with AMR, which is a ambulance company, the fire department, because she's calling 911 a lot, the case managers from the health plan that she has, me from our hospital, and there was somebody there from Stanford Hospital, and we came together and just tried to brainstorm what can we possibly do to help the patient feel more comfortable. And really underlying everything is this anxiety she has. And so, and there's one point of contact, and she seems to respond well to this person, and so we want to keep that person there. So Eddie has been really, really helpful to us, and our program has used it a lot.
That's incredible. And kind of along those lines, we have one other question from Harvey is, for your hospital, how many behavioral health or social health staff do you have to help?
Yeah, so our hospital is around 241 beds. And so we have a behavioral health service that's part of our hospital. And we also have pretty large, so in our emergency department, we have coverage of case managers as well as social workers. So social workers, I believe we have about 10 hours of coverage per day. And then in our specific program, Peninsula Circle of Care, we have about 3.0 social worker.
Great. Thank you.
I think behavioral health, is a gap that we're really, that a lot of times is the reason for the high utilizers that are coming in. A lot of times they have a history of behavioral history, and we're really trying to figure that out, and that would be kind of a next step going forward. Is how do we engage with behavioral health? How do we connect them to mental health resources?
Wonderful. Thank you.
Great question.
Okay, moving on. So now we're going to do, get down to the nitty-gritty of how do we engage and activate patients. Something we came up with, next slide, or next point, it's called Heart of the Matter. And this came out of a conference that Yvonne attended, and she came back and said, this is what they said, let's try it. And so it took a little time, about a month, for us to come up with the one, looking at what's that low-hanging fruit, right? What's that one little thing a patient can accomplish, a family member can accomplish in a short period of time, right? And we don't necessarily limit it to a medical thing. It could be a social thing. It could be a personal thing. I want to be able to do my puzzles again, my jigsaw puzzles again. Or I want to be able to interact with my grandchildren, or things like that. And really, this was very good, because I have to be, I'm embarrassed to say, when we first started the program, we had a 38 question questionnaire that we asked patients. So we came way back, we pared way back down and got more down to what is the patient wanting, what can we help them with so they don't get overwhelmed, and then just having someone acknowledge concerns of the family, concerns of the patient, you know, reassurance, you know, how can we reassure them and be their partner in accomplishing things, that they're not on their own. We are here to help. I say, call me anytime. I will answer the phone. And so the next slide, you see Maslow's hierarchy of needs. I didn't, but so the next slide, this is a, go ahead and click again. So when I do a home visit, I kind of stop myself at the door and before I knock, and I just kind of sit there for a moment and quiet myself down, not bring anything in with me. When I step into their house, I'm in their house. I'm a guest. I introduce myself. I say why I'm there. I might have to repeat that. One of the things that we do hand out sometimes is this form that you see on the right. It's just a simple, this is what the nurse does, it's social work, wellness. I put my name and number. It's in one place, and they have it. We can put it in a folder for them. Sometimes they have their own ways of managing the medical information, however they want to use it. And my first question always is, how are you doing? And then I wait until they answer. And usually the thing that comes out of their mouth is the most important thing to them. So I really want to hear what is the most important thing. A lot of older adults, they're in a stage of life where they just want to, you know, be. And I you know, I kind of like, oh gosh, can I do that too? You know, just be in the moment and enjoying their grandchildren, doing activities, you know, and maybe a hospitalization has impacted this. And so what is the most important thing to them? I inquire and listen, and then next steps. So if sometimes I'll hear, you know, I really want to go back to going to my exercise class. And so how are we going to get there, right? And they're like, I'm so tired, I have no energy. And I'm like, I have to explain, you've been in the hospital, you've been in bed, maybe up walking once or twice, but, you know, so you have to give yourself time. I really encourage people, you know, that you are exactly where you should be. And I try to like normalize their experience for them, even though it's not normal, but other patients have told me this also. You're not alone in this. And then we talk about next steps. What can we do? And I always thank them for the information. And I really appreciate the interaction with patients. I mean, that was the heart of our program, really. And we had good staff that were very good at interacting with patients. And the goals will be what the patient wants, what family members need, you know, and we're going to follow up on that on some other area, another slide, and review other items with them, possibilities for the future. Next slide. So here's some strategies for connecting. I told you a couple. One was, you know, taking and being present in the moment with people. Acknowledging success, right? We don't do this enough. And I tell you, like, that was great. You called the doctor and already made your appointment. We have that off the table now. I know you're going to go to your appointment. We use coaching. Coaching is a way of okay, this is what other people have done. And sometimes the best way to, you know, manage your symptoms is to do a scale, you know. Oh, your pain. Okay, let's look at pain, right? I do a lot of pain management because I love it. But I say to a patient, you should never let your pain get to a 7 or above because it's so difficult to bring it down. What's an acceptable pain level to you? And usually they're pretty low, like 3 or 4 is okay. And I'm like, okay, we can work with that. You know, and I say when we get to 5 or 6, this is when you need to do something, so you need to check it. So it's a coaching kind of idea. Motivational interviewing, we did many sessions of education for ourselves on this. And it's really pulling out information in a one-to-one. I always think of, I don't know if anybody knows Martin Buber, but he wrote, he's a German philosopher, he wrote I and Thou, and it talked about the betweenness between people. And so I kind of look at that like, I'm no better than you, and I'm here to help you, but I want you to feel important too. And motivational interviewing does that, kind of empowers. Education, I'm an education girl. I like education. Sometimes I might do too much, but patients have told me that they appreciate understanding their illness better. And I can do it in a slow manner. I have an hour for my visit when we usually did visits. And also on the phone, again, I can reinforce. Proactive approach, you know, share options, agree, disagree. Summarizing the visit, this is so important. Summarize and doing transitions. So you do transitions from one topic to another and then summarizing the visit. So you're okay doing, you know, filling your pill box next week, and then I will look for a resource for you to get some help with your depression. And that may be the summarizing the visit, right? Very simple, very straightforward. You have one task, I have one task, we're gonna work together. All right, next slide. Leveraging patients' goals for self-efficacy. So our goal really is to help patients and become that person that feels comfortable taking care of their medical and social needs. Now, it may be that there's other partners in that. It may be that they're on their own, or they have a husband or wife or child, or, you know, nieces and nephews help. So that's just making sure that they feel comfortable doing something. And if they don't feel comfortable, I do it with them. Next. So the skills transfer is transferring the skill and feeling good about able to make a doctor's appointment with their PCP. Now, can you call the new doctor, the specialist, and make an appointment with them? And then we coach, let them know you're in the hospital, you need a sooner appointment, blah, blah, blah. So the picture to the right, this is part of motivational interviewing, called the plate method, but it's kind of offering up different things. This is a person who wants to exercise, right? And what are different ways of doing that? Well, one of the simplest might be doing stairs, or might not. You know, maybe doing a class or walking, you know, or parking further out in the parking lot, whatever we do. This is just an example. There are many things we can do. Next.
This is about, let's go as well a little bit more. So this is about presenting the options.
Yes.
And have them choose, what would you like to work on? These are the few options we've discussed, or you express an interest in working on. What would you like to do now?
Yeah, I always ask them, so out of all the things that we discussed, what's kind of the thing that you like the most? You know, what is the thing that you think you can do? Leveraging all of that in together. Next slide.
And sorry, really
Go
quickly
ahead.
before we go on, can you repeat the name of the author, Martin something, in the book that they wrote about?
Buber. It's written in German, but it's been translated into English. And it's I and now. Talks about the part, and it's kind of, I think of it as the space between me and the other person.
Mm.
And so when I'm in a home visit, I try to sit within 3 or 4 feet.
Mm-hmm.
I sit within ear so they can hear me, you know, that
Mm-hmm.
kind of stuff. So it talks about this between this. It's not a concrete thing. It's like, why are we human beings?
Mm-hmm.
And how do we interact with each other?
Wonderful. Thank you.
And appreciating that. Yeah, he was great. He's great. Okay. So, you know, we talked a little bit about barriers. Sometimes it's people feeling their own barriers, family members, maybe it's family dynamics or others, but you can do this, right? I want to make sure people feel that they can do this and give them permission to take charge. You know, sometimes people are hesitant for whatever reason. And then if they are hesitant, then that's where I jump in and I model it for them. I might give them something to say when they're calling the doctor's office. And then also, next slide. There we go. What's next, right? So identify readiness for change. Some people are in the pre-contemplation stage. Some people are in contemplation stage. Some people are, okay, I'm going to make this goal. Next. This is just ready, set, go. We have 30 days to work with the patient, but our wellness coach could work up to 6 months with the patient. So if they wanted to work on something more, this person could do that.
Some of it may be also making sure that the patient is comfortable in taking the next steps. Because if the goal is let's find some resources for you to get to meet new friends. Well, I don't feel comfortable going to an activity group by myself. We might say, okay, let's go together. Let's check it out. Or if they're not comfortable calling the doctor to ask for a sooner appointment, it may be, why don't we call together? I'll stay on the call, I'll listen in, and I'm happy to jump in if you're not comfortable. So it's kind of how do we hold their hands as they take that very first step.
And the next slide. So we asked some questions at the end of our 30 days. What did you change in your healthcare? What would you recommend? Would you recommend the program? And I'm just going to let you read them. I'm not going to read them for you. What goal were you able to accomplish?
Something that we did as part of our program is we've also completed qualitative studies where we interviewed patients that have gone through the program, where they tell us how they felt. And so some of it is about, they felt that they are now feeling more confident and empowered in managing their health. Or they felt, the family caregivers we've also interviewed, and they said, wow, now I have the tools that I needed to move forward. Or they felt like their capability has increased. And they've also expressed an increase in their confidence and their engagement, family members, confidence and engagement in caring for their loved ones. So we have really, again, a lot of it is really hearing from what patients and family members are telling us at different time points. Yeah.
Okay, next slide. So thank you for having us. We're happy to answer questions. Lindsay, if you want to.
Yeah, thank you, Linda and Yvonne. This was very informative, and I congratulate you on all of your incredible work to reduce readmissions at your organization. I was really excited to hear that patient family advisors, and you really incorporated the advisory council in the development of this program. That's really awesome. So congratulations on all of your incredible work, and thank you for sharing with us. At this time, I will open the line, and so you can take yourself off mute by hovering over your screen and clicking the mute button, or if you're on your phone, I believe you can press *6 to unmute, and we'll open it up for any questions at this time. And Jessica, I do see your question in the chat box. Where can you access the recording? We will post the recording by next week. It will be posted to our website, and I will put that in the chat box. And Stella asks for Yvonne and Linda, is there a specific readiness tool that you utilize?
Well, no. There's not really a tool. It's my interaction that determines whether somebody's ready or not. Sometimes I might push a little, and if I get pushback, then I know they're not ready. And then I do a more hands-on approach. Like Yvonne talked about, maybe we used to have wellness coaches. We'll meet you at the senior center, and then I'll go with you until you feel comfortable. So readiness for change is different for everyone. Maybe it's not this hospitalization, maybe it'll be in the next one, but we're really trying to set the groundwork for people.
That's good. One tool I was thinking that we use from the staff end of our program is a tool called the PAM tool, Patient Activation Measures, PAM, and it was developed by Dr. Judy Hibbard from University of Oregon. And the tool is about a patient's activation level. Are they highly activated, or they're not as highly activated? And what it means is someone that is highly activated, example, would be someone who just received a diagnosis of cancer, for example, and they would go out and do all kinds of research. And the next appointment, they're actually asking their doctor whether they can try out the latest and newest option out there. So this is an extreme example of someone who's highly activated. Versus someone who is not as high activated, if they're given a lot of information during a hospital stay or by providers, they get overwhelmed and they don't really know what to do. And sometimes they feel like a failure, or sometimes they feel like they don't have the tools because they're being asked to do too much. And so that's a great tool that helps guide a lot of our interventions.
Great,
I
thank
forgot.
you. Oh, was there another question?
No.
Oh, okay. Another question about just more clarification around EDDI. Charlene just wants to clarify that it's an electronic interface that numerous healthcare facility electronic records, but it's not a portal through which patients would access records. Is that correct?
Yeah, that is correct. And I'm happy, Lindsay, to send you the website for those of you who are interested in learning more. At this point, I don't believe that they have opened it up for patient access. No. I think in a lot of the healthcare systems, there are patient portals that they can access. So, for example, in Sutter Health, we have something called My Health Online, where patients can directly email, they can directly message their providers and also view their own records. But at this time, I don't believe there is an option. But they are opening up access to primary care providers. So for community doctors, for doctors that are seeing patients, or for others who are touching patients from a provider's perspective, there is an option to open up access.
Great. Yeah, if you could, any resources that would support everything that you've been working on, we can definitely send all those out after and follow up. And then we have another question from Harvey. Are you familiar with TCYH self-management program from Stanford?
TCYH. No.
No. Take care of your health. Nope. Okay.
Oh, take care of your health. Okay.
This is the chronic health management series that they provide from Stanford.
I am not sure. And Dr. H, if you would like to come off mute and pose your question, you can do so.
Excuse me, the Take Care of Your Health program at Stanford, two doctors at Stanford did in taking charge and or teaching self-management, one for diabetes and one for chronic health conditions. And it's been around the world in I don't know how many different languages. And I've taught the class myself. It's a 6-week self-awareness class for diabetes and for chronic health conditions, where people sign up and go through a scripted program, and people, it's free, and I forget the name of the doctor who actually started the program, but it has been out there for 20 plus years.
Great.
That's great.
Yeah, definitely
No, thank you
something to
for
look
sharing.
into. Thanks for sharing. Were there any other questions for Linda and Yvonne? Okay, well, if there aren't any questions, I see. Thank you, Linda and Yvonne, for sharing your information as well. I'm sure they would be happy to answer any other follow-up questions that you might have. I appreciate everyone for joining this month's February workshop. Thank you, Linda. Thank you, Yvonne, for your incredible work and for sharing the implementation of this project with all of us. We really appreciate that. We will be posting the recording to our website within a week, and Linda and Yvonne were very gracious enough to share the presentation slides with us. So once the recording is posted, I'll send out a follow-up with the recording, the link to the recording, as well as the slide deck and any other resources that we have to share with all of you. So again, thank you all so much. Have a very happy Friday, and I'll give everyone 3 minutes back to their very busy days. So thank you.
I just wanted to say our information is on this last slide. If you want to email us anything, any questions.
Wonderful.
Thank you. It's been our pleasure.
Thank you.
Great. Thank you so much, both of you and everyone, for joining. Have a great day.
Thank you.
All right. Bye-bye.
Bye.